I'm actually a pathologist by training, and I head the Department of Transfusion Medicine, which includes clinical pathology and immunogenetics. Also developed an interest in information sciences, and from my postgraduate days have been closely involved with development at CMC, and had the opportunity to do a fellowship in pathology informatics at the Henry Ford Hospital in Michigan. So it really widened my perspective, and on getting back, I continue to work with the IT team at CMC Vellore. I have something to declare. I'm an honorary non-financial advisor to a company called Society, which primarily looks at, it's a startup by some ex-IIT guys. We're looking at providing healthcare IT to smaller, rural, remote hospitals, and to see how we can keep the cost down, which is an important factor we'll be discussing today. The Christian Medical College is located in a small town about 150 kilometers from here. We like to think of ourselves as a city, and now we are on the list of 100 smart cities. So we think we are a smart city now, or we are going to get there soon. But I still think that we are a small town. We are kind of trying to be a city. Over 100 years, our founder was a Christian missionary lady called Ida Scudder. She was a physician trained at the Weill Cornell University Medical School in New York. She came back in 1900 to start a hospital, and that's where the first one-bed clinic started. And over the last 118 years, we've become 2,800-bed facility, seeing more than 2 million outpatients a year and 130,000 inpatients every year. We have more than 9,000 staff. We are accredited by the National Accreditation Board for Hospitals. Most of our laboratories are NABL accredited to ISO 15189. And our turnover is over 1,000 crores this year, and more than 150 crores of that goes as charity. So we are a for-poor, not-for-profit organization which is located in a small town, offering everything from primary care in the community to tertiary care and highly specialized high technology care in the hospital location. The little red dot shows us where we are, and we get patients from all over the country. So in the next few slides, we'll go over the decade starting from 1970. Prior to 1970, we really continued to depend on typewriters. From 1970, we started our first dabbling with information systems with a punch card system. We didn't have a computer. We used to travel here to Chennai, to the IIT Madras, to use their mainframe to do our computing work. In those days, we started with payroll and then went on to billing section. So somebody used to travel with all the punch cards over here, generate the bills, and travel back by bus. It used to take 4 hours or more each way in those days and back then. In 1988, we had a startup called CHIPS, which stands for Computerized Hospital Information Processing Services. That's what they chose to name themselves back then. It's still retain the name. It's our enterprise IT department. And this was actually headed by a very innovative, visionary plastic surgeon who had an interest in IT. And so it leads us to the first point that we need interested clinical people if you want to drive IT within healthcare. Just a quick show of hands. How many of us are clinical people here today? Like, not bad. We at least got a smattering of them inside here. And then we went through the 80s with analytical automation, centralized lab reporting. The 90s, internet came in, and we were all sitting with our little modems which made all the beeps and sounds, and tried to get internet at home and email at home. A lot of process automation happened, mostly for back-end services, laboratory, and for billing and appointment scheduling. The most, I think, important thing which happened during towards the end of 90s was when we decided to get picture archiving and communication systems, digital radiology, and we still continue to have the same vendor and the same product. It is GE Centricity. I see it as a watershed moment in our history because that brought a computer terminal to every doctor's desk and every ward, and so suddenly IT was there right at the bedside or right at the doctor's desk for use, and thereafter there was no looking back, and more things have got onto the same platform. We in the decade of 2000 to 2010, I'd like to highlight the first iteration of what we call as an electronic health record. We're just really not imaginative. We just call it clinical workstation. And that's what it's been called all these last 16 years. And it's designed around the doctor's workflow, helps the doctor to see patients, manage patients, and then take care of them longitudinally. The next important thing I wanted to highlight there in that decade also was the next step which we took in terms of patient safety. And people often don't think much about barcodes. We see it every day, we use it every day, but not inside the hospital sector. There are very few places where we use it. But a very low cost solution like barcodes has really helped us step up the quality of care and reduce our error rates for patients. In the last 5 to 6 years, we've gone on to Oracle node-based architecture with redundancies. We've also started investing in our own development for a PACS system, which runs in parallel to the GE system. We are not doing radiology on it. We're trying to get all the other departments which do imaging studies onto that. So that kind of gives us the background of how we evolved and how we reached where we are today. All outpatients. We have about 1,500 to 1,600 computers on what we call a clinical services network. And the clinical services network actually caters to all patient care related issues. The network is a closed network. It is only on the private side. It's a virtual network within the hospital. There is no internet accessible on it. You can't check your email or surf the net or check out Facebook while you're on the clinical services network, which also leads us to a big advantage that it is a sterile network, and we keep it that way because there is no devices allowed onto that network and there is no internet connectivity. You can't plug in a thumb drive, you can't do anything with it. You can only work with the applications which the institution provides. So all those 1,500 computers run without an antivirus. And so there is a huge cost savings when we look at how we run that system over there. And that's used exclusively for patient care and for administration. We have office networks, which is outside the clinical services network, where internet is allowed and other applications can be. So this, when I was preparing for this particular talk, I just thought of what are the areas where we are working on. And in keeping with our mission statement, which I showed you earlier, we primarily work in education, service, and research. Now, education and research, as I will address towards the end, are really neglected areas as far as IT is concerned. And most of our efforts have gone towards providing services, both clinical and for infrastructure and support services which are needed to manage. So what is our model that we have implemented? There's really no 1, 2, or 3 things that I could put together to tell you what it is. But essentially, I think it reflects the core values of what the institution stands for. We try to keep the patient at the center. So most of our development has happened on demand for patient care and around patient care workflow which is required. One of the most important things, I think, was the leadership which we had. I talked about Dr. Philip Kurla, the plastic surgeon who started off this effort. There have always been clinicians who have been interested and have been able to give their time over and above their routine requirements to help and sit down and design and help the IT guys to bring in what we needed for our patient care. It has always been driven by need and demand. There are rare occasions where we just buy software and keep it aside. And because of this, most of the software, I think about maybe 90% of the applications that we developed are actually being used on a daily basis. Resource constraints is an important consideration. Like, nowhere in the world is resource unlimited. And especially in our country, I think we have to be extra careful about it. And we have a both-and philosophy where we take care of patients who cannot afford, which is cross-subsidized by the patients who can afford in the hospital. And so therefore, we have consciously tried to minimize external dependencies. So what does it take? Number one is having the people who are interested, people who are committed, and people who are willing to go the extra mile. As some of you may know, our salaries are not hotshot. It's not what you might get around in other places around the world. But there are people who are determined to make the best of what we have and are willing to walk the extra mile for it. And I mentioned the name of the late Dr. Philip Kurla over there. The second is having insight. As you saw in my earlier slide, IT actually pervades the complete functioning of the hospital now. And today we are talking about taking it to the next level, being remote, having patients have their own access, and having patient data flowing in from outside where they are. So it takes insight to bring this together and to bring it together in a way that is non-threatening to the clinician who's not familiar with this, at the same time allowing them to have maximum interaction with the patients the way that they want to. So what happens to cost? There really isn't too many studies from our country, I think, which talks about cost in IT healthcare system. But I have a couple of slides, a couple of studies here which I have cited, one from Boston University and one from AHRQ. And they're a little conflicting, so it depends on how you look and what metrics you use. If you want to say that yes, there is returns, and or no, there isn't any returns on it. But I'm sure with all our experience put together over here, and our personal experience from our own hospital, there is really no going back on IT investment in this day and age. For the 1,000 crore rupees that I showed you over there as a top line, our own investment in IT is about just under 1% of our total top line is what we spend on IT. So it's very different from what companies like PwC have put out over there, saying 10% for a big healthcare institution. We are way below that in our IT spending at this time. So we run a really lean operation, and there are costs which I'll talk to you about. So this is another challenging place, and this is my favorite cartoon if you can't read it. The last one talks about, it's actually Dilbert discussing with his manager as to how do we manage timelines in IT projects. And this is a real killer for all of us. And I think some of the important things is that because we have an in-house team, we really get very highly customized software at the end of it. It's highly usable software that we get at the end of it. But the big problem that we have is change management and changing goalposts. Every time you go back to the clinician, oh, that I just want it this way, or I just want to change the button, or I just want this whole screen changed the other way around. Or now I didn't know that we have to see the patient at this point in time. So those kind of interactions keep happening. But ultimately, I think we win out because the product that we get is so usable and user-friendly at the end of it. Next, please. So what has not yet worked for us? Integration of best-of-breed applications. So we, like I told you earlier, because of our resource constraints, we develop most of our applications in-house. So it's still a challenge to get applications like centricity to talk to our systems with all the problems that we have with interfaces. Platform independence. We are largely a Microsoft house, and we're dependent on Microsoft's changes. And so we live with it, and we struggle with it, and we curse it and kick it on some days, but we still have to live with what we have. So those are challenges that we get. We are now moving on to mobile platforms. We're not quite there yet, but we're just starting to work. We have always been challenged with outsourced development, and we really do not have an easy way to bring in outsourced software which is developed outside into our hospital. We collect a lot of data, and a lot of our workflow is managed because of IT, but we have really not a good model to utilize the data or to monetize the data or knowledge that we have collected over the years. We have done very little for education. Mostly it's student management and e-learning. We have a platform from the Tufts University called Tusk, which we are using. And for research, there's a lot of potential, but it's highly underutilized. We do have a few partnerships which we started up in the last 4 to 5 years, looking at image analysis, NLP, and data mining areas. So what's left? What concerns us? Move towards standards, move towards authentication, unified patient identification. These are things that we need to worry about, we need to think about, and Sir was talking about the law has not been challenged yet. But we need to be a little more proactive and see where we want the laws to be. There are other countries which have invented this for themselves. Now we need to do it for ourselves as well. Obsolescence, a constant challenge in our life. How are we going to keep up? And the philosophy of continuous improvement versus don't fix it till it's broken. Don't fix it till it's broken, and then it becomes legacy software, like somebody was discussing. We don't keep up with the times. Opportunity cost, the cost of the untaken choice, the untraveled road by taking one choice. Often I think in our institution we don't talk about it enough, and so we delay things and we do not make decisions in time. So that brings us to my last slide. I'd like to thank my colleagues back at home, and just a quote from Henry Ford: that failure is simply the opportunity to begin again, and this time more intelligently. I think we should be out there, large institutions which can afford to make mistakes, not expensive ones, but correct it and get on again with it. Thank you very much for your attention.